Hi everyone, welcome back. Hope you've had a nice break. So this is the final part of this COVID-19 update session today. So thanks so much for bearing with us. Another reminder, all of the videos and presentations you've seen today will go offline just while they're processing, and they'll be online ready for everyone to view. So please share them with whoever might find them useful. So this final session is about how to prepare physiotherapists and anyone else, any other healthcare workers, any other therapists out there. We're really inclusive about how this information is used, but how to prepare our workforce for COVID-19. And I'm delighted to be joined by Darren Brown. I'll let Darren introduce himself in a moment, but we're going to mix it up slightly and talk about the patient experience of COVID, and that follows on so nicely from Dorothy Wade's talk. And also why this is so special is because Darren is also a physiotherapist. And then we're going to talk a little bit about aerosol generating procedures and about pathways, because I know everyone is so, rightly anxious about that. So Darren, welcome. Do you want to tell us a little bit about who you are, where you're from?
Yeah, hello, thank you for having me, and hello everybody that's watching live and also in the future if you're watching on demand. My name is Darren Brown. I'm a physiotherapist. I live in London in the UK, and I specialise in the rehabilitation of people living with HIV and or cancer. I'm both a clinical and an academic physiotherapist.
Thank you, Darren. Now, Darren was really generous with his time yesterday and two other physiotherapists, and recorded a whole podcast on his COVID-19 experience. So please do reach out and watch that and watch, the experiences of others. But for now, and obviously this is a live session, it would just be great to take us back to your COVID-19 acute phase, when you were diagnosed, when that time when you were unwell, and talk us a little bit through that. Thanks.
Yeah, absolutely. So I contracted COVID-19 in March this year, and that has been later confirmed on blood testing, so both fingerprint testing and also antibody testing. So it's been confirmed that I had an antibody response, which was useful because then it confirmed that the symptoms I had were due to acute COVID-19. So I came down with acute COVID-19 on the 20th of March earlier this year. I came home from work, was incredibly fatigued, didn't do my usual Friday evening activities. I didn't even make dinner. I just fell asleep on the sofa. Don't remember getting to bed, and then woke up on the Saturday morning with a cluster of different symptoms that I immediately thought was COVID-19, because it was in March. Patients had already been admitted to the hospital where I work with acute COVID-19. So it was very present in my mind. The symptoms I had were headache. I had breathlessness. So, for example, I was bedbound for 48 hours and I would be breathless, just literally rolling over in bed. I had pain, so that was in my muscles and also in my joints. I think probably one of the most disabling symptoms was actually the fevers, with fluctuating body temperatures, whereby I would be boiling hot and sweating and then freezing cold all within the space of an hour. I also had, he's challenging my memory now. I also had, I can't remember now. It feels so long ago.
And this is the brain fog, isn't it, that you're still experiencing with your memory?
Yeah, and actually I feel exhausted from those podcasts yesterday. So I'm struggling a little bit today.
And I think this is the reality and this is the realism, and I'm so grateful that you're here today to kind of exemplify that, because Darren is like this incredibly intelligent and a highly academic, he reads so much, he writes so much, and that's one of your biggest frustrations, isn't it? Because at that moment in time, you were redeployed into the front line, and which was the right thing to do for people who were able to do that and had the skills to do that. But when people became acutely unwell, had this massive hit of symptoms, felt like they hit a brick wall, were absolutely flawed, but then they had this false sense of security because the symptoms then just resolved quite quickly.
Completely. Like if I think about the timeline of my symptoms, I was off work with acute COVID-19 for 2 weeks. And I on Facebook was doing like a daily diary of like what was happening. And I've copied and pasted that all into a Word document. So I've got a record of that for my own history. And actually, the first 48 hours, the fever was the worst symptom. By far, coupled with the breathlessness and the headaches. But paracetamol helped me with that. But like by day 3, I kind of jumped out of bed. I then even tried to start exercising, like doing yoga and stuff. But I noticed that I was getting lots of fatigue. But by the time I returned to work after 2 weeks off, I felt ready to go back to work. Like I still had some symptoms like fatigue, but I felt ready to go. And I think that as you described that false sense of security, even though I was potentially anticipating that there was going to be unknown long-term consequences of COVID-19, which we are now learning is long COVID, however that may be defined, I did have that false sense of security. I threw myself back head on straight away. And that was when everything was changing in my setting in the UK and London, where a lot of staff were redeployed, which included to acute medical wards, high dependency units and intensive care. And I did all 3 of those actually over that time. So I think you're right in saying that false sense of security was there, even though we didn't know the long-term consequences, because I felt like I'd recovered. And I wasn't anticipating that I would now, how many months is it gone? It's like 9 months now, and I'm still not firing on all cylinders and still struggling. And just for those people that may not be aware, I'm actually just coming to the end of now being signed off work for 2 months with long COVID, and due to return back to work next week on a phased return.
So one of the problems with people, and one of the problems with anyone who works in kind of healthcare sector or any public facing role, I think when you deal with people, the human side of us wants to get back to work, wants to rush back to work, doesn't want to let people down. And that guilt that people experience because we are in a pandemic, and if that individual has been hit by that pandemic, then there's a feeling of guilt and duty to go back really quickly. And that's exactly what happened to you, isn't it? And you, as you said, carried on for what was actually months before you then were absolutely floored. So you kind of touched on that, haven't you?
Yeah, it's interesting because I think the word guilt is quite laden and comes with strong connotations that maybe I don't know that I necessarily associate with, because I think that being in healthcare is often a calling, right? It's a vocation. It's a life. So I don't know that necessarily there was a sense of guilt by not returning. It was a duty. It was my responsibility to be back because I wanted to be back, because it's not only my job, it's also part of my identity. So I think that the times that I felt guilty are when during this 2-month period of long COVID, where I've had good days and you then start to question your symptoms and go, why am I feeling good today? And then, within the space of a day or 2, you've probably done a classic boom or bust and pushed yourself too hard like I did yesterday, and then pay for it, and then, and then you realize, no, I'm not normal anymore, am I need to still pace and take my time. And so I think that the guilt is that there's a layer of it, but there's so many variables to it, because there are times that, for example, 2 months ago I couldn't work, and in March I couldn't work. I couldn't get out of bed when I was acutely unwell. So I think it's nuanced, that sense of guilt.
Yeah, and one of the challenges for people who are suffering, like you said, this long COVID, what is probably going to be named as, we're still waiting for a formative definition, which is really hard, because the long COVID side of it, when you're in a pandemic for 8 months, and yes, obviously we're in the 10, 11 months for some countries, is really difficult, because any kind of long-term condition you want to define, in terms of having this a large enough group of people that share the same symptoms and then know what to do them is difficult. But what we know now in terms of how to manage these long-lasting effects, and we've had a great presentation from Sam and OT on this today, is about not just pacing yourself, but just giving yourself time for recovery. Yeah. And when you have a younger population of people who may never have been hospitalized before, and this includes physiotherapists, occupational therapists, any type of therapist, giving yourself your own advice is really difficult. So from your perspective, what have been the things that have really helped you personally as a patient, but also speaking as a physiotherapist with these longer term effects?
I think the biggest thing that has helped me has been having a positive practice environment. And what I mean by that is, so the World Health Professions Alliance are currently releasing a big campaign about positive practice environments. And for me, that was not being pressured to be back in work when I couldn't be back in work. Having the time off to stop, rest and pace has been so important. On the back of that, pacing. I thought I understood pacing, but boy, I didn't understand pacing until I've had to do it myself with my own health challenges. So with the fatigue and with the post-exertion malaise, because you can say you understand that physical, cognitive and emotional exertion can set you back, but it's only when you realize that the simple things can set you back and you just don't realize it. For example, being involved in two podcasts yesterday has set me back today. I felt so much better yesterday. I felt full of energy. And today I feel like I'm running on 10% battery and literally only just got ready in time to attend this. So, and you just, and that wasn't even that exertional. I was sat in a chair yesterday, so it's not like I'm getting up and dancing. So I think that pacing, learning what is exertion, has been so challenging but valuable. And something as well that I think has been really useful to manage kind of the uncertainty or the worry about the future has been something that I learned from the field of HIV. So we know that people living with HIV can experience episodic disability. So these trajectories of episodic disability can either be kind of worsening, improving, mildly fluctuating or stable. And we know that the hallmarks of improving and stable episodic disability is acceptance and optimism. And I think for me, that's been really valuable to learn to accept the disability that I've experienced, to accept that I can't do what I used to be able to do, but be optimistic that I will be able to get there again. For example, I had a cognitive assessment this week because of the brain fog, and it's quite traumatic to realize that your brain isn't working in the way that it used to. But I'm optimistic. I've been through my body and me have been through a lot with this, and I'm optimistic that things will improve. So I think in summary of that, the things that have helped me have been recognizing my triggers in terms of exertion for fatigue, but bearing in mind that many people with long COVID have a cluster of symptoms and it's not just fatigue. Pacing has been important, but also being able to be supported to rest, but then also acceptance and optimism.
Thank you. And again, this ties into some of the other presentations, but it's about looking after that physical and mental health. Yeah. And again, the population affected by COVID, again, typically a younger population than what would normally see, just aren't aware of that. And I think that's where that hitting that wall comes from, because people will think, oh, well, I'll rest, but I'll read a book, or I'll do some work, or I'll work on my laptop. And certainly we've had patients say to us, I can't even watch an hour of TV. I watch half an hour and then my concentration's gone. I have to get up, I make a cup of tea. And it's not even until they're completing their fatigue diaries or that, that they're realizing that every single activity is so short. Yeah. And there's just no retention there. The short-term memory loss, the lack of engagement in certain activities as well that they'd normally enjoy, they just don't want to do. And then the frustrations that partners or significant others will experience, because they're like, why don't you want to do this? Why won't you get out your pajamas? Why won't you get up off the settee? Why won't you go for a run? And some of that, again, I suppose guilt is the wrong word, but what the connotations that come with that can then just, again, this cycle, what someone's been in who's living with COVID and long-term COVID.
I completely agree. And I think that maybe the word that I would use with that is hesitancy to be open about the symptoms that you're experiencing with certain people. You know, we live in a particular geopolitical landscape where there are very varied opinions on this epidemic, and also people's health experiences or health and disability experiences. So I've been very precautious and hesitant with who I speak with about things, because you can maybe not have people that understand you or are willing to understand. For example, the friends that I've spoken to the most are people that I trust and value, but also people that have maybe experienced things like friends with ME, or friends with vitamin D deficiency, or friends with depression, that actually, they get it. They actually get it. Whereas other people have not, and maybe have really struggled until they've maybe had the opportunity to physically see you and realize that you're not quite there yet.
Absolutely. So that, I'm not going to keep you too long, because you do look exhausted.
Thank you.
No offense. And we've done a whole podcast on this last night, like I said. But what advice do you have for people out there, healthcare professionals, physiotherapists, like, who are looking after COVID-19 patients, either in, you know, the acute phase, and what would you recommend in the longer phase?
I think that something that's been really useful for me has been measuring the nature and extent of the disability that I've experienced. And I've been using the World Health Organization's disability assessment schedule for that. It's only a 12-item questionnaire, it's self-reported, and it's enabled me to identify what domains of disability I've been experiencing. So, for example, I did it a month ago, and you get a score of 0 to 100. 0 is no disability, 100 is full disability. A month ago, my score was 68%. I did it again yesterday, and the score was 14%, which demonstrates how much I've improved. But I think because of the nature of this, whether it be acute or long COVID, it's multidimensional and it's episodic. And I think we need to be mindful of that, which is that this is not going to be a linear trajectory for many people. There are going to be ups and downs and fluctuations and many variables that can exacerbate or alleviate the disability that people may experience.
And I think that's a really nice point. And actually, we've got some comments coming through on the chat, but from the very start of this pandemic, we know the significant after effects of a severe respiratory virus. So we know post-intensive care syndrome exists, which are a lot of the symptoms that our post-intensive care COVID patients are describing. We have a model for that, which is PICS, post-intensive care syndrome. But also those non-hospitalized patients with COVID-19 are definitely have post-viral fatigue. Now, there is very strong links with chronic fatigue syndrome / ME, and certainly the experts in this field have been saying for some time we need to be mindful that this could develop into chronic fatigue syndrome or ME. We're just too early in the process to say whether that will happen to everyone, and people are very anxious about that, thinking that they're going to have a debilitating condition for the rest of their lives. So I think everything you said about managing it in the acute and post-acute phase is so important, about us recognizing that the effects will not stop when someone's discharged from hospital or within the 2 weeks of isolation that they've had. To look for triggers and look for triggers in others. Like, let's be kind to people. If you notice someone's being a bit more irritable, who, you know, they're on social media and they're putting comments on, and you're thinking, oh, that's a bit, you know, whether they're at work, whether they look tired, whether they look exhausted. And, you know, it's like, you know, are you okay? Like, are you really okay? Yeah, I'm noticing X, Y, or Z. That is the best thing you can do to support someone. And then signpost them. You've mentioned already in the Physios for ME website, has been mentioned a few times. great resource of information. The respiratory society, so the BTS, the ACPRC, all of this kind of stuff is open access. And of course the COVID recovery documents as well, so the NHS COVID recovery document and the Lancashire Teaching Hospitals recovery document, and there's QR codes which we can send out and post online, and it'll come with a PDF of this as well, that you can just scan on your phone and you're away, or you can just use a hyperlink on the internet. So
another thing that just came to my mind, Rachel, is actually around models of rehabilitation as well, because I think that in the context of this being multidimensional, episodic, with unknown long-term consequences, I think our traditional linear models of rehabilitation, where we kind of start, get better, stop, discharge, I'm not really sure that that's going to be as effective for people. And I think we need to maybe consider open access models of rehabilitation, whereby people can attend, return, restart, depending on their episodes of health, wellness, illness, or disability. And that might even be that with whatever long COVID services become available, or other existing services trying to fill that gap or model to the needs of people with COVID, I think that would be something that I would ask people to consider, which is that what's the permeability of your service for people to be able to come back when their needs change?
Mm-hmm. Oh goodness, Darren, if we could have a needs-based assessment for rehabilitation for patients based on need, not on diagnosis, that's our gold standard, isn't it? That's what we were aiming for, not just in the UK, globally. The problem is resource, isn't it? And I think that's, every country has their own problems with resource, some absolutely more than others. And for some of it, with specifically the COVID-19, it's about self-management, but it's about understanding what is the right self-management. And you're absolutely right, we've changed our scope on that. In the beginning, a lot was kind of around pulmonary rehab. That's definitely not the right model of recovery for these patients. And like you said, graded exercise is definitely not the right rehabilitation strategy. So yes, everything you've said there is completely spot on. And I suppose it's just reinforcing the message and getting the message out there, which is exactly what you and others are doing.
You said there were some questions, Rachel. I'd be very happy to answer any if there are.
Are you sure?
Yeah.
Okay, you do have some comments on Twitter as well, but people have put them to yourself and emails. So what's the hardest thing about living with COVID-19? Like from your perspective, you mentioned all these symptoms you've got. Can you pinpoint one of the hardest, what you think's one of the hardest things?
Uncertainty. Mm-hmm. If I was to give it one word, because through the whole time that I've lived with this condition, disease, virus, whatever you want to call it, I've had 3 different phases: acute, return to work, long COVID, and none of it has had like any stability in it. And it's just been completely changing throughout the whole time. And so you can't really set a baseline. You can't really set a new, this is the level I'm starting from and I'll build up on. And that just creates uncertainty. And unfortunately, that also creates worry. So I think that's probably been the biggest thing, not knowing what's next.
Thank you. Now, one of the other things is, so as therapists, where therapists are very anxious about starting rehabilitation in terms of physical rehabilitation because of the debilitating breathlessness and fatigue, but also very concerned about the bigger, like public health, bigger impact on that person for not starting rehab. And, how long do you need to tell someone to rest for and limit their physical activity? Like, is it that an impossible question to answer, or?
Yeah, basically. I don't know. Like, I must admit, like, this is something that I'm currently trying to navigate myself. Like, I, over the last week, have felt virtually symptom-free and was thinking, right, maybe I need to start considering doing some self-rehab, getting back into some exercise. But I decided that I was going to do other things. So I was going to do the cognitive exertion. So participate in things that might feel more normal, like the podcast, like the webinars, like Zoom meetings. And that's been the rehab in itself for me, because it's recognizing my limitations and recognizing how I need to repace. What's my current moving goal of a baseline to work from. So I don't know that I've got the answer to that. Like, I think what's really interesting is that, you know, with the fatigue, I've experienced so many different types of fatigue. I've experienced acute viral fatigue. I've experienced this fluctuating, self-limiting 24-hour periods of fatigue that didn't seem to be exacerbated by exercise. And I've experienced this fatigue which is coupled with post-exertion malaise. So over the course of these 8-9 months that I've been living with this, I felt like, depending on the type of fatigue I was experiencing, depended on the response that was required. I don't know whether I have had different types of fatigue. Maybe I just didn't really know the symptoms well enough. But I think something that would be really important is to stratify people's symptoms, because, you know, not all fatigue is, if we look at every health condition and fatigue is a broad symptom, exercise can be amazing for that. For example, cancer-related fatigue, or people living with HIV that experience fatigue. Exercise is probably one of the most effective interventions for those people. But if we look at the other side of that, you know, people living with ME, or currently people living with long COVID, that experience post-exertion malaise, well, clearly exercise interventions are not going to be appropriate. So there needs to be some stratification of the symptoms that people are experiencing to better address and prescribe interventions that are going to be appropriate for them. So it always comes back to person-centered care, specific to the needs of the individual.
Yeah, and certainly in the UK, the model we're looking at the moment for long COVID is almost like a one-stop clinic shop, where a patient comes and has a variety of tests and diagnoses, because some of the breathlessness and anxiety can be caused by other cardiovascular effects of long COVID. So we need to exclude other pathologies that may be going on at any long-lasting kind of systemic effects of COVID. Then you should be, and this is, a lot of this is just my opinion, be assessed by a occupational therapist, physiotherapist. The thing with occupational therapists is they're very much taught about mental health as well as physical health, whereas physiotherapists don't tend to, in the UK, be taught, have much, you know, training on cognition and assessing cognitive impairments, which can be very, very subtle in your post-viral patients. It's not until you go in and do a screening tool or go ask those questions that will lead on. And then, of course, the psychological impact. So, and then if you identify ongoing rehabilitation needs, if you like, whether they be physical, whether they be cognitive, whether they be psychological, then we'll access those services in the community. Now, for other countries, that might be really, really difficult. So the advice that we're giving is to use the simple screening tools like we've showed today, use the experiences of people like yourself on what it's like to be the patient, what you need, what advice you need. That simple advice at the right time could be the difference between you pushing yourself to another relapse, or, well, maybe relapse 100%. Is the wrong word, but, you know, like this episodic.
I think it is the right word, because, you know, people are describing kind of these relapsing, remitting symptoms. You know, I've forgotten his name now. The doctor in the UK, I think he's based up in Liverpool. Oh God, Paul.
Yeah, I know the chap you mean. He was on my slide yesterday.
Yeah, and he wrote something in the BMJ blog, didn't he, about relapsing and remitting symptoms. You know, I think that relapsing is an absolutely appropriate word, but I know that, you know, something that I've used and we discussed yesterday in the podcast was crash. Because actually that's what it feels like. It doesn't necessarily feel like anything other than you've just hit the brick wall and you've dropped, and there's no movement forward. But I think that the one-stop shops would be amazing. They don't exist yet. And I don't know what they're going to look like or what their permeability is going to be. Because, you know, I've still got symptoms. You know, I've got cardiac symptoms. I get tachycardias for random reasons. And, you know, I've got an iWatch and I've been measuring my ECGs, and then, yeah, they're a bit strange. Still waiting to be seen by cardiology.
Bless you. Well, just a couple more questions and we are going to let you go. Any tips for active rest when you are normally active and driven? And Daria, who was on the call last night, she did mention, didn't she? Because she's a dancer, and she was like, this is something I've really struggled with being a runner, and so active rest. So you see, normally I would coin that as things like reading, but you're still cognitively.
Yeah, you're not lying down in a dark room with your eyes closed and doing nothing. Yeah. I haven't got the answers for that. I don't know. I'm really struggling to navigate that. I'm not going to lie, because I am a very motivated, driven person. And so most of the time I'm just active and struggling to rest, full stop. So I think, do you know what? I would probably say that if you're active, you're probably a bit like me, and learn to actually rest. Like, what is actually rest?
Love it. And the final one is someone that didn't need admitted. Did you see changes in your heart rate, SaO2, and links with exertion and symptoms now? Now, you mentioned in that acute phase that you were like, you were looking at your sats and you were checking your heart rate. Like, what about now, and is there a link?
Yeah, so within 24 hours of having acute COVID-19, I was on Amazon Prime and I bought a pulse oximeter and a sublingual thermometer. So I was measuring my symptoms all the time. I never had desaturation at any point during my journey with COVID-19. My heart rate has been all over the show. So during acute, I did have some mild tachycardia at rest, nothing more than 110. But during my long COVID phase, I've had really quite significant tachycardias using my wearable device. So, for example, I've had periods whereby if I say 4 or 5 weeks ago, I would be walking out of my flat down the stairs and my heart rate would go from stable resting 60 up to 180 and take longer than 10 minutes to recover. And that's not normal for me at all. I'm constantly measuring my heart rate actually with my wearable, because that's been something that was advised to me by physios for ME, which is heart rate monitoring, to try and prevent or mitigate and alleviate the post-exertion malaise. So I have noticed that, and actually that's, I think, because of the level of health literacy that I've got, it's enabled me to have a conversation with my GP about that and say, I'm concerned about my heart. We know that some of the studies, like for example, the cover scan study, has demonstrated that people living with organ damage, including, cardiac myocarditis and people having other organ damage such as pulmonary, liver and renal issues. So I advocated for my needs, and hence why I'm waiting to be seen by cardiology to investigate my heart fully, because I am still having fluctuating tachycardias for unknown reasons.
Well, thank you so much, Darren. Like I said, we've got a full hour and a bit on this online. Just have a look in the other YouTube videos and you'll find it straight away. Thank you so much, Darren. You've been amazing.
Thank you for having me.
Good luck in your recovery, and we really appreciate your advice. Now go and have a rest.
Oh, I'm going to. Thank you all. Bye-bye.
Bye, Darren. So I'm aware I've had you all for a long time today, but I do just want to finish off on aerosol generating procedures and the impact for physiotherapy. So please do put any of your questions in the chat box now, because this is going to be quite a short session to close. Just a reminder as well, for any of you that want to collect CPD points, whether you're watching this live now or whether you're watching the rerun, please fill out the online Google form so you can get your CPD points as well. Kim, I've just seen your question there about starting community rehab or when wearable devices. So in our community-based rehabilitation settings, the ones that where they are commissioned, they will have just pulse oximetry tests to start with, and they'll be monitored throughout, just like we would do in, say, cardiac or pulmonary rehab. Those services, I believe, are few and far between. When people come in, when they're admitted, they do get their exercise testing, so we kind of know their limits, and if they've got any exertional desaturation. So that would be our advice in terms of the smartwatches and, you know, activity trackers on watches. Then, you know, we generally, patients will purchase them themselves. And any kind of standard activity watch will tell you, you know, your heart rate. As Darren said, the advice is that heart rate monitoring is a really effective way to monitor, you know, and grade yourself in terms of what you do. So I'm going to try and share my screen now. If you just bear with me. Any questions about aerosol generating procedures, please do just pop them in the chat. So this is Anya, one of our physiotherapists, before she's going into one of our red zone ICUs. So this is a standard level of personal protective equipment for our physios that are working in COVID environments. We have what we call COVID risk managed environments now. So their patients are either COVID positive, or there's a high likelihood that they're COVID positive, i.e. they haven't tested negative and they're a high risk patient. There are also areas where we know there are aerosol generating procedures being performed. So that typically includes invasive ventilation. Now, our government and Department of Health, combined with a specialist group called NerveTag, produce a statement that lists very clearly what aerosol generating procedures are. But for some procedures and interventions that we perform as therapists, so that's in physiotherapy, for example, chest physiotherapy, upper speech and language therapist, videolaryngoscopy, or anything where you're really in close proximity of the patient and there's a high likelihood of cough and aerosol dispersion, would be deemed a high risk procedure. So in the UK, what we've tried to do is to think about what is an definite AGP and what is high risk procedures. Now, anyone is welcome to this, which is a copy of my own trust, infection prevention control measures, as well as care pathways and clinical settings. You might not be able to read that very well, depending on where your view is, but I'm more than happy to share this document and put it online. So most trusts in the UK will have something like this. Now, what we've done, because we are a specialist heart and lung hospital, is we've devised our own rehabilitation and therapy directorate list of what is defined as an AGP or high risk procedure. Now, if you're treating patients in the acute environment, there is pathways where patients can be admitted. So low risk would be patients that are being self-isolating at home. They've had very little contact with people. Obviously, we're in national lockdown now, so nobody can mix with anyone unless they're in the same household or they're in a very specific social bubble, either for childcare or for caring reasons. And therefore, there is a very low risk of potential transmission or carriage of the virus. And this is our second lockdown because obviously our infection rates have soared again. So we have a low risk pathway for those patients who come in, and they will also potentially, most likely, be tested negative for COVID at that moment in time. Testing for COVID obviously is based on availability of the testing kit, but also it's a test at that moment in time. And as we know from many studies, testing someone at one moment in time, if the viral load isn't significant enough to be detected, patients then go on to have a second test which is positive, and also vice versa. So a lot of this is based on likelihood, a lot of it's based on risk management, and the default is always to treat as positive until it's proven otherwise by a negative sample. And this is also really important because we know up to 75 or 80% of all carriers can be asymptomatic. And there's some great studies out there published on Thorax BMJ. So I also work for Thorax British Medical Journal, and if you go online you'll find some podcasts around this as well, particularly in healthcare workers. So patients come into the hospitals in pathways, and in the community setting it's similar in the fact that with a lot of high-risk vulnerable patients that you might be seeing in the community, they will almost be shielding themselves. We've got some very high-risk patients, for example, with very severe asthma on long-term ventilation that have been shielding pretty much since December last year. And I think that's one of the reasons in the UK we haven't seen a high incidence of patients being admitted into critical care with, say, neuromuscular disease or any complex respiratory conditions. So we have personal protective equipment tables. This tells us based on what likelihood the patient is to have COVID-19 and which pathway they've come in at and what level of PPE that we need. So you can see in those very low risk areas, there is a requirement to always wear a surgical mask indoors. Now that's a government rule regulation, and you must wear face masks or face coverings in any enclosed space in the UK, whether that be a shop, whether that be a hospital, whether that be school, and obviously that translates all the way through the pathway. It only changes when you get to the high risk group, when you need an FFP3 mask when you are undertaking AGPs. So that's a really important point to note, that in the UK we're using face masks as standard, and they are non-fluid resistant surgical masks. So they are the hospital type masks that you see. And we also encourage all patients who can wear the face mask to wear the face masks, and that includes during any type of rehabilitation and pulmonary/cardiac rehabilitation, and that's in the acute community setting as well. So with physiotherapists that are performing any type of AGP or high risk procedure, and I'll go on to what they look like for us, the minimum level of PPE when a physiotherapist or a, say, speech and language therapist is performing a procedure, we wear surgical masks and a visor. And again, if anyone's interested in reading some research, particularly from what we learned from the SARS epidemic and pandemic back in 2002 to 3, there is some really good studies to show the effects of visors and eye shields for healthcare workers in terms of reducing droplet contact with the face and the facial area. So we definitely use surgical masks and visors as well. Now the visors can be used completely, used again, they're reusable. We wipe them down with chlorine-based wipes, the special hospital wipes. We wipe them down and then we leave them in the red zone with our names on them. Obviously, we wouldn't reuse them between different people, but we reuse them amongst ourselves. Depending on the area you're using them for, you could use them for days, or you just throw them away at the end of the shift and use a new one in the morning. We do that for two reasons. One, because it's perfectly safe to do that. It's not, we don't reuse the masks. Obviously, they're single use. But we don't have an issue with PPE at the moment, but we're just very mindful of reducing waste. So again, you won't be able to read all of this, but why I'm showing you it is just because this is what we have decided to do, and almost every organisation, I would say, which has a respiratory physiotherapy or respiratory therapy service, will have a list of what AGPs are, but also specific AGBs for physiotherapy staff. And you can see here that within our list is very much around what would be defined as an AGP, is standard yes or no. And for the majority of things that happen within a critical care environment, they are of course an AGP because the patient's on invasive ventilation. We, again, are a specialist heart and lung hospital, so we have a different cohort of patient. Every single patient that comes into the Royal Brompton and Harefield is a respiratory or cardiac patient. So our patients are already at higher risk, but we have detailed, in a lot of detail, as you can see, exactly what we would define an AGP, a high-risk procedure. And if it's defined as yes, that means all staff should wear enhanced PPE, which includes an FFP3 respirator, the equivalent of N95, or an individual respirator to help protect themselves, and wear a visor. If So for example, the field exercise test, the 6-minute walk test, or the shuttle tests, they are not defined as AGPs. The patient is actively mobile. The patient will be wearing a surgical mask. Now it says surgical mask if able, but if we're performing the test in a hospital or in a community centre, the patients must wear a surgical mask. If they're outside, we are trying to perform some of our screening and exercise tests outdoors, just as an innovation to try and continue with assessments when we have limited indoor space because of social distancing. Then the patient, if they're intolerant of masks, may be excused from wearing them, but the physiotherapist or technician or anyone else who's performing the test must stand at least 2 meters away from the patient, and they will be wearing a face mask and a visor. So active cycle of breathing techniques was a really interesting one. In some of the other devices, for example, breath stacking. Now, it's really important to remember that cough is not defined as an aerosol generating procedure, but it definitely produces and disperses droplets. And this is why the visors are really important, because when you have something that's not defined as an AGP, but will produce droplets, and we know that SARS-CoV-1 and 2 is spread via respiratory droplets, then wearing a surgical face mask may not be enough, because the routes of transmission are obviously through the face, and then people have droplets on their face and then touch their mouths. But as well, wearing eye shields or eye visors can only increase your protection. So even though cough is not defined as an aerosol generating procedure, it will definitely affect droplet spread. And I can send you some really great articles if anyone wants to learn about that in more detail. So this is just an example of the table closer up. And again, it just will really break down the different types of what an AGP is. So I'm going to stop sharing my screen. So there's a slight delay on the YouTube from when I'm speaking. So please, if you do want to ask any questions on AGPs or physiotherapy or any other practice, please do so. This is the end of the day. Like I said, the videos and the presentations will disappear offline just because they need to be processed. And as they're processing, there's a delay sometimes of a few hours. If they're not up by the end of the day today, they will be all live online tomorrow. So you can all watch. Please do fill out the Google form if you would like to get CPD points for this. This is from the Namibia Physiotherapy Association. And I just want to say a massive thank you for all of you that have interacted through the audience, and just a massive thank you to all our panelists and speakers today. We will be putting on an international day over the next couple of weeks, so keep your eyes peeled. It'll be a specific physiotherapy one, and we'll also be putting on a full multidisciplinary team day that will be accessible to all as well. So just checking the chat. No, there's no questions coming up. If you do put any questions in and I just can't see it, please just put your email in and I will reply, or just reach out via the Eventbrite booking or via YouTube, or of course via Twitter at HP Leader. Okay, thank you so much for your time and enjoy the rest of your day. Stay safe.